Hello, hello. Thank you for joining me for an overview of the define phase. So today we'll be talking about healthcare quality and performance improvement broadly again, but going into the first phase of Six Sigma, which is defining our problem. So where we left off in the Module 1 overview was really talking about some of the broader issues, such as external stakeholders. We have the Joint Commission that is our predominant accreditation organization in healthcare that most hospitals work with. We have organizations like NCQA, National Committee for Quality Assurance, that most health plans work with. And then we also have a lot of other smaller agencies. We have federal agencies like the Department of Health and Human Services and the Center for Medicare and Medicaid Services. And all of these organizations have specific requirements. They have standards, or as far as CMS is concerned, we call those conditions of participation that have to be met. And so those are elements that kind of keep us afloat, if you will, from a healthcare quality perspective. We have to hit those standards. We have to engage in that space as health services administrators. But a lot of what we're going to be talking about in this course is about doing the right thing, doing things well, and doing things with purpose. And that is more than just meeting a standard. That's putting our patient first. And so we'll be talking a little bit about how to work above and beyond these minimum requirements. One of the changes that we saw with the ACA and a lot of the legislation in the 2010s was a move towards something called a National Strategy for Quality Improvement in Healthcare. And so we moved away from just saying that we want to cut costs, increase access, increase quality, to the idea of better care, quality again, healthy people, healthy communities, kind of access and population health, and affordable care, cost. It was a rebranding, if you will, but with a lot of federal funding and effort and energy behind it. And I don't want to be negative, but we've seen, the last 10 years, a lot of efforts in that space and a lot more work to be done when we look at increasing outcomes and making improvements in our health system. Now, when we think about federal health policies and oversight, a lot of our role in health systems has to do with providing care and then providing data back to these agencies and demonstrating what we're doing. And so these federal agencies, they're acquiring knowledge, they're doing research, they're asking us for data, they're pushing us to be more transparent with our data, and they're creating these financial incentives. Now, just as CMS has done that, right, with the Medicare and Medicaid plans, private health plans have followed suit. They have their own financial incentives now, their own quality metrics we need to hit. And so these are all things that we need to be aware of. As you work in a health services administration role in different organizations, you'll work with different organizations that have different goals, some of which are tied to financial incentives, some of which are must-dos, some of which are things that are reported as a percentile or a rate, and 0 is better or 100 is better, right? All these things that we're tracking over time with the ultimate goal of translating that individual, wonderful, patient-centered patient experience into data that's on a spreadsheet that shows thousands of satisfied, healthy, well cared for patients. And that's our goal, right? When we think about the data analysis piece, is seeing those individual stories translate into true positive population health outcomes. Now, when we start out addressing an issue, and I'm just going to go over some of these slides today because I know it's a lot. I've got a lot of different resources in this file. When we think about addressing a problem, the first thing we need to do is define the problem. Dr. Leiter, who I have borrowed a lot of these resources for, also calls this the design phase. So if you're thinking about project planning, you might call it the design phase. In Lean Six Sigma, we call it the define phase. We have a project charter. We have a voice of the customer, which is a tool that we use, or many tools, to pull together, and we put that into something called the VOC table, but an overview of what the customer wants. And then you'll notice the list goes on, and I'm going to go through several of these tools today, but we have the Kano model that looks at attractive quality versus must-have quality. We have brainstorming tools, and we have diagrams that we put all that data into. The idea with this phase is that we want to plan and understand the problem that we're addressing fully so that we can start going into the next phase where we document. We go from define DMAIC, DMAIC, to measure, where we start gathering data. We watch the process. We time how long it takes from the patient to get from OR to PACU, and we go through all the data together. That phase that happens next has to happen, needs to have a precursor, the define phase, that's a really clear statement of the problem. All right. So I like this Dwight D. Eisenhower quote. It says, "In preparing for battle, I have always found that plans are useless, but planning is indispensable." I live by this. Now, not specifically as it relates to, the art of war, or what a general would think about related to planning an attack, but as it relates to team building. I've had a lot of meetings where we changed our mind. We didn't end up doing what we thought we would do in the meeting. And somebody would say, well, that meeting was useless. And I will say, was it? I now know you, you know me. I have three people I know by first name basis in IT. I've met three more nurse managers, right? We all know and like each other and understand each other's way of communicating. We've normed. It was not a waste. So much of what we do is about team building so that every time we address a new healthcare quality problem, we can move faster with more precision, with more empathy. We understand the hot buttons for certain people, what certain people like to work on, what other people don't like to work on, what the skills are. The planning process, the process of norming and figuring things out together, figuring each other out sometimes, there's a lot of value in that beyond just one particular project. So, one of the key tools that we use and what you're asked to do in almost any course you'll take with me that's healthcare quality centric, but this course is to put together an example project charter. Now, project charter can be a Word document. It can be a form you fill out in a database. It can be a presentation file. It's just an overview of what the issue is and what we think we're going to do about it. It's very high level. It has information about the team, the initial scope. And the one thing on this page that maybe you don't initially know what I'm referring to is this piece down here, operational framework. That's what approach we're taking. And in most projects that I lead, the operational framework we're taking is Lean Six Sigma. We're using tools from the Lean and Six Sigma methodologies. That's our approach. You may be taking a waterfall project management operational framework approach or an ISO 9000 approach. There are other approaches, but based on the tools we're learning in this course, the operational framework you might be using is Lean Six Sigma. You'll choose specific measures. We talked about structure, process, and outcome measures during our last course, right? The resources you have, what you're going to do with them, what you expect to achieve. And then, of course, what support you need. So this is a high-level document. A lot of time we spend crafting our background and purpose, why this matters, why organizational leaders are coming together, how quickly it needs to be solved, all of that background information. It also helps to have a mission statement or a thesis statement specific to the project. And sometimes it helps to tie the mission statement of that project back to the mission of the organization itself. Why is this project so important for who we are? How does it tie to our values and who we want to be? Then we have the scope. Now, a lot of projects, if you've worked in project management, have large scope documents, big IT projects. We write pages and pages about what we're going to do. For an initial project charter for a quality improvement project, all I'm asking really is what's in scope and what's out of scope. What are we doing? What are we not doing? What nursing units are included? What nursing units are not included? For example, I worked on a really cool project, getting the right type and dose of insulin to certain patients, basal bolus insulin protocol. We worked with all patients in all nursing units except for the ICU in that particular project. That's the scope. All nursing units except for ICU. So things like that are just high level. Maybe it's just a project that impacts the lab. That's your scope. We want to make sure we're really specific about the team members and then specific about giving credit to people. Even if they're not in the meeting, who's going to be doing some of this work? Honoring those folks, giving them a voice and a place is really important. You will be much more successful when you take time to do that. Sometimes we have additional consultants or support staff, making sure that everyone is given credit, that there's clear lines of accountability is really key. And then again, that operational framework, In our case right now, we're using DMAIC, our model. We're going to define, measure, analyze, improve, and control our problem, our quality improvement issue. That's what you'll do for your final project for the course as well, right? Think about how you would do that for a sample project. That is what we're doing. That is our operational framework, but it can be any planning paradigm. A lot of different organizations use different tools and different approaches. And then, of course, we have our measures. And this is an overview of what it means to have good structure, process, and outcome measures. I know I talked about that in last week's lecture, right? It really helps to know what you have and what you need resource-wise, what you plan on doing with that, and what the outcomes are you expect to result. Really nice and clean. Now, sometimes these are short-term outcomes for individual patients. Sometimes these are long-term population health outcomes, right? Sometimes it's a mixture depending on how long you're collecting data for. Now, the next 40 or so slides are different tools that we use. So I'm going to be going through these rather quickly. There's a lot of content on these slides, a lot of examples. I've used a lot of these tools. And you'll notice sometimes I'll post examples of the tools, little sub-lectures about different tools, YouTube videos so you can get familiar with them. But not what I want you to learn right now and remember for the next several lectures as I talk through different phases and different tools is not every project requires you leverage every tool, right? Certain projects fit a certain approach. They fit a certain type of effort. If you're looking at improving timing and efficiency in lab, then you'll use a lot of tools because a lot of tools have to do with reducing takt time, that amount of time it takes per lab specimen, right? They have to do with increasing efficiency, with getting, teams engaged. You'll use those tools. In other cases, if you're just looking at increasing the percentage of a certain form getting signed by the physician on time, you may not use those tools because you're really focused on just getting that physician signature. So instead, you're going to focus on maybe automating that, reminders and process engagement. It's going to be different. Every project's different. So I just want to say that. So the first tool we'll talk about for a moment is a set of tools called gathering the VOC or the voice of the customer. Anytime we want to know what's critical to quality or what's the most important outcome we want, our ultimate goal and our driver of that goal, our driver is our X, our outcomes are Y. We want to look at that critical to quality equation. What change in X gets us to Y? We have to figure out what matters first. And we do that by capturing the voice of the customer. We create a listen and learning culture. We get our customer demographics, and then we figure out how are we going to gather feedback and input? How do we figure out what is important? Now, sometimes this is redundant. We know exactly what is important. We know exactly what we're doing and why. It's already a problem and we know why. But quite often we need some outside input. And so we can get stated input where it's very documented or unstated where we're observing. We're gathering information, but it's not stated. Now, both versions can be formal and informal. Anytime I craft a data collection tool, a survey, a focus group, an interview tool, that is a stated formal tool where I'm asking people for feedback and it's clearly documented. But sometimes we have a quick questionnaire where we walk in and ask them a few quick questions at discharge. But it's not always the exact same questions. It's whatever the discharge nurse feels is important and she documents it. A little more informal, but still stated. Informal is more about observation again, but also about looking at what is quickly available, right? With unstated formal, that's sometimes the stickiest category to pin down. These are things that are very specifically documented, but aren't stated complaints or concerns. So we're often getting it from somewhere else. We're looking up data in a warranty database. We are doing a very structured observation of their behavior, so it's formal, but they're not telling us how we feel. We're observing them in a very formal way now, though. So you may choose a very formal or informal way of gathering customer input. It may be more through things that are directly said versus not, stated or unstated, and these are a few examples of those methods. Either way, we pull that all together and we put it into our voice of the customer analysis, which quite often is a VOC table, a table of everything we've looked at. Now, to give you some ideas of where to start, we have some really cool stated areas of data that are already available. Most hospitals and healthcare organizations, health plans, outpatient centers, long-term care collect data. And a lot of them work with big vendors like NRC Picker, Press Ganey to get that data. Now, it is a federal requirement that we survey Medicare patients who are hospitalized, and Medicare and Medicaid patients get surveys related to their health plan outcomes. A lot of these organizations have to capture some data. Many choose to do a random sampling, though, of all. Every 10th, every fifth patient discharge gets a phone call. I know that I've been through a lot of health services recently and I get a lot of phone calls for surveys. So that data is stated data that's already captured in validated survey format, right? Now keep in mind that that survey I was referring to of patients that are Medicare patients that are seen, that is something called HCAHPS when they're seen in the hospital. It's the Hospital Consumer Effectiveness of Healthcare Provider Survey. Those types of surveys are available, as you can see here, for health plans, hospitals, PCP offices, dialysis clinics, and nursing homes or long-term care, just to start. Now, in addition to the formal listening methods that we've already covered, you can also look at things like likeliness to refer. How many patients did you have, and then how many translated into a family member or friend getting referred? That works for certain services. Doesn't really work for cardiac bypass surgery, right? I don't know that cardiac patient knows another cardiac patient, but for some things, right, especially those optional services or those more elective services, that works. A lot of this data is taken and put into something called the Kano model, which is a way of looking at different customer requirements, different things your patient wants, and organizing it between what we really must have versus what we'd really like to have, what's kind of a nicety, or what we call an attractive quality, the icing on the cake, if you will. And then what things do we absolutely not want to have, reverse quality? What things, if they're present, bankrupt our system? They ruin the experience, right? Things like that. So these are some formal listening methods, focus groups, questionnaires, some informal, again, quickie questionnaires, right? Not like a long survey that gets sent to them via email or a phone call, but more of, a quick hop in the patient room, ask them a question. Maybe looking at social networking data online, social media data. Now, all of this gets encapsulated and interpreted through the lens of the Kano model in many cases. This is a model of looking at what people think is important in a product or service like healthcare and what hurts their satisfaction versus helps. If something is present and that thing being present hurts satisfaction, it's reverse quality. For example, if I go into a hospital and everybody there is on their cell phone and no one's paying attention to me and I'm confused as a patient, that's reverse quality. So cell phone usage by staff, volume of minutes spent gaming on their cell phones during their shift, that's a negative. Attractive quality is things like I go into the doctor's office and I don't need it, but they offer it. I recently went through another cancer diagnosis and treatment. And when I went into my oncologist's office the first time, there was a mini fridge there with beverages. I hadn't been to a doctor's office with a mini fridge in a while. They had water. That isn't something I need in health services, but it was kind of cool. It made me feel special. That's an attractive quality. Must be qualities things I need. I have an amazing oncologist. That's something I need. I need a great surgeon. I need a great doctor, right? So if it's there and it's good and it's special, those are our exciters and delighters, those special things. The things that we must have are attractive, not must have, the good things, whether we need them or not, attractive, right? They're things that bring us in. Things we don't want are reverse. So attractive's good, reverse is bad. Exciters and delighters are those special things, and then we have the basic needs. So my apologies if I said attractive like it's standard. Attractive is just anything good, right? And I've got some definitions here. Now, I will say there are some things that are indifferent. Sometimes customers don't care. For example, a water bottle might have felt special to me when I was nervous. You might say, I don't care if they've got water bottles or not. I brought my own tumbler and I don't want to create waste. Great, great. But it just kind of made me feel like someone cared about me, right? So for some people, something could be attractive, while to other people, it's indifferent. Individual perception, right? But we look at that as a whole. So we'll go through and we'll collect all this data. We'll do surveys, we'll write up a short summary, we'll take it all together and we'll look at what really matters to our customers. And we analyze the results, step 6, within the context of this graph. What do we need to have? What could we add to make an extra special impact, the exciters and delighters? And how do we bring that all together? And we do that, all of this together is a voice of customer stakeholder analysis. Now, in addition to talking to our patients, we may talk to our suppliers, our managers, our leaders, our partners, other people delivering the same service, right? Sometimes we want to cast a bigger lens, and I know I've been focusing on the patient because that's the lens that I often think about, but a bigger lens for that. Now, we want to make sure that we determine who's important. And this, I always joke about this. I'm going to show you a graph on the next slide. This slide here is describing a stakeholder analysis where we look at someone's impact as a stakeholder on our project. Now, I very rarely use this in its entirety, and there's a couple different reasons why. I don't think it's cool. I don't think it's nice or appropriate to go to a meeting with everybody plotted on a graph and say, you're really important, you're really influential and knowledgeable, you're not so important, but you take the meeting notes. I don't like that, but this is a view of someone's impact, right? Their influence on a project and how important they are in the organization. And we map those. Do they matter a lot to the project? And what is their role in the organization? How much power do they have? I need the CFO on board. We know that. But this is a visual view of that. And I have worked with projects that have done this. I had a template in Excel once upon a time that I would use as a project manager when I was asked to. But this is not a tool that I recommend we heavily utilize. It's important to do the work of figuring out who your stakeholders are, to vet them, to make sure you engage them in getting their voice, to care about them, to understand their influence. I don't know that we need a graphic that makes them bigger or smaller based on input or that moves them around based on importance. I just don't, it's not my favorite tool. That being said, folks together and making sure everyone is important. Maybe wouldn't rank everybody in a live session like this tool recommends, but I would ask folks, did I involve everybody we needed for today's meeting? I'm planning a meeting 2 weeks from now, another session. Who do we want to make sure we really engage? Who is on the floor doing this work? Who from the lab can come join us next time, right? And who can I give credit to for the good work that's already being done? So this is that bubble chart process. Again, you don't have to do that. Now, a lion's share of the slides in this week's lecture talk about process mapping. And that's what we do in the define and measure phase. We map out a process like admitting somebody to the hospital or moving somebody from pre-op to the OR to PACU and taking care of them. We map it out with steps and roles and people. And then we make sure we're doing it right. We look at the amount of time it takes. We look at opportunities for failure, mistakes, and we use that to make a better future state process. We move from a current state to a future state. That is process mapping. Now, process mapping produces that graphical workflow, and it allows us to focus on steps, get rid of any that don't contribute value. We call that NVA or non-value added work. This is a basic flowchart example. And I said I was going to keep this high level, so we're just going to talk about 2 more tools after this, but I want to spend a moment looking at this flowchart. This is a flowchart that talks about how we stratify risk for patients. We do something called a health risk assessment, and this is very common when patients are new to a health plan or a disease management program. We look at their risk level. We have them fill out a survey or we fill it out with them to determine their health risk. We look at their claims. What procedures, what surgeries, what diagnoses, what's going on with them health-wise. And together that helps us stratify risk from low through high. And then that helps us determine, do they just need some educational materials? Do they just need a reminder to go to their appointment, maybe some monitoring? Or do they need to be in a focused case management program where they have an assigned case manager helping them? This is a basic flow chart. Now, this specific one's for diabetic care management, but I've seen this approach used. Most health plans use this to determine the types of resources they provide you. When we make a flowchart, these images here are the basic flowchart symbols. Now, different softwares use different versions. There are different approaches, but these are the old school, tried and true, see them everywhere symbols. A process start is normally a rounded box like you see at the bottom. A process is normally a perfect square or a rectangle. A document or a report is normally a top of a rectangle with a little swoopy. The end of a process is more of a circled, long, extended oval of a rectangle. A decision point is a diamond. Those I've been using for 20 years, mapping processes in different health systems. So these are accepted, standardized approaches. So we start out by determining the scope and boundary. We list out the steps, and then we start to put them into the little symbols, right? Again, standard process steps are just a square. So normally we're going from a slightly rounded square, lots of squares, a couple decision points, maybe a report that we're analyzing, and then a process end that's that long rounded symbol. Does it always have to be done this way? No. Does everyone follow this? No. But does it set a certain standard of professionalism if you can read this, understand it, and replicate it and make your own? Well, of course. So we want to know and try this. And this is just a little overview of a process you can follow for obtaining that information, drawing it out, getting feedback, and finalizing it with your stakeholders. Now, there are other types of process maps. One of them that we use is called the SIPOC. And I've got some examples here. This one not only maps out what you're doing, it puts people in the right buckets. So this, for example, is a lab process. And we're going from the physician entering the lab all the way through the end. And in addition to having the flow, we also document who the suppliers are, what the inputs are, what the outputs are, so we know what's the point of this process. Oh, it helps us get the laboratory report. And who do we need to participate? Oh, we need a clinical pathologist, a lab tech, and lab suppliers. Okay. It's a more detailed approach. And so in order to do that, we have to identify each of those pieces, who the suppliers are, what the inputs and the outputs are. I've got a lot of examples of these, so if you're curious, send me a note and I can always share examples with you. But what I'm going to say really quickly is just like any tool, not all my examples look the same. They don't all have the same data or information in them. Different organizations have their own visuals that they use. Different organizations call this a SIPOC versus this. I have some that are much more granular where every step of the process has a supplier and an input and an output. You don't necessarily need that level of detail for every process, but sometimes it can be helpful. Now, the last section of today is all about brainstorming and brainwriting and something called NGT or nominal group technique. And so this is where we're going to round out today's session or this session. Nominal group technique, NGT, and brainwriting are more formalized approaches to brainstorming. Now, brainstorming, as you know, is an open collaborative process where we're throwing out ideas. But quite often in quality improvement, we need a way to document and capture that. Maybe you use your AI meeting notes, right? Maybe you're writing down ideas on the wall. But what's important is that we understand that even if it feels casual, there's a defined purpose. And if we've got 15 people in the room that all make 30, 50, 100, $200 an hour, right? We have a surgeon in the room. We want to leverage that time in a really smart way, even if it's just brainstorming. And so it's important to realize that brainstorming is about throwing out all ideas. You hear that term, no idea is a bad idea, but of course we want to be ethical and equitable and appropriate. So the way that we phrase that in brainstorming is it's quantity over quality. Get as many ideas out to start just getting things loose. Because quite often you don't settle on one of those ideas. It ends up being a derivative, right? A downstream idea that flows out of that. The idea is to build on one another's ideas and to develop a body of information to work from. So with brainstorming, we have a clear problem, right? That's what the define phase is all about. We summarize the background, we get the right people in the room, and then we prepare for the session. And I love doing this. I like to use Zoom's whiteboard now. I use sometimes just a Google slides presentation, and I'll have everybody put up little text boxes. I used to use a Google product that did that for you. Unfortunately, they got rid of that product. But we prepare for the session, we get our materials together. Maybe we've got a flip chart and post-it notes, or we do the digital version I was talking about. And we throw out a few questions and start to get people to document. Now, what I like to do that I always have used is I like to throw out a problem and talk about what we're currently doing about it, what we can do that's reasonable financially and logistically and resource-wise, and what we would do if we could do anything. If you had any amount of resources, what would you do to solve this problem? Because sometimes that gets people to just say what they're really thinking, to throw everything out there. And then we can adapt. Maybe we can't do that idea, but maybe there's a slightly cheaper version that we really can do that nobody thought about. So that's part of that. So we conduct the session, we get everybody in the room, we identify a timekeeper, right? Because having a time limit is really important because how you encapsulate and prepare information depends on how much time you think you have. So sometimes we don't get to the end of a discussion because we thought we had more time, versus if we knew we only had 5 minutes or 10 minutes, we would have started with first things first, their idea first. So that is general brainstorming. None of that probably feels very new to you. What I want to really quickly talk about is that there are some variants, and one of them is called brain writing, one of them is called NGT, nominal group technique. Brain writing is where we get folks together and we actually have each team member write out their ideas on a page. At the end of the time, you share it with your friend, you pass the idea on. So it's not as anonymous sometimes as some approaches can be. They know it's your idea, but you keep passing the idea on and reviewing each other's. That is how brain writing works. It involves writing it down versus shouting it out. Now, I like to do versions where ahead of the meeting, we all put our ideas in a spreadsheet and then we discuss them together. I like that. Nominal group technique's a little bit different because if you have, and I love it because if you have group members that are really outspoken, like me, or some that are maybe almost a little oppressive or just they dominate the meeting, and it happens, I'm not trying to be negative, but it happens. What you do is you pre-prepare. So you clearly state the subject. You allow 5 to 10 minutes for each individual to write down their ideas, right? You gather the group together, and then each team member reads one idea to the rest of the group. The facilitator writes it down on the flipboard. No discussion at that time. You just read them out. And then you can move on if you want. And there's a lot of different approaches to this, but you can move on to list reduction, where we vote for ideas that are just on the board. And that way, everybody's idea got said at least once. And then we start the discussion and the consideration. Um, the last few slides here talk about something called list reduction, which is where we take all the ideas and we boil them down, all of our proposed ideas. And I've done this a lot. I used to be a paid consultant, as some of you know, and I used to do a lot of work in my leadership roles where I would get groups of people together and we would get all our ideas out there, and then we would reduce them down to an action plan or some sort of strategy. With that, there's a couple different approaches, and we're going to talk about two of them. One of them is called multi-voting. And I love this because you can circulate a document and have people vote. You can have them put little stickies on something, on the things they want to vote for. There's a lot of different approaches that this resource recommends. But what I like about it is it allows us to choose many ideas and to slowly filter down. So how list reduction normally works is, let's pretend this is an old school session and we're all in the room together. And this happens a lot still in health systems, right? I used to lead a lot of these and I really enjoyed it. We put all our ideas out there and we can either upvote or downvote them. But how about we take all the ideas and we combine them? We get rid of any duplicates and we get the rest of the names in a list. And maybe they're still up on the wall. Maybe I've manually combined the duplicates and put them up, all our post-its, or maybe they're in a document in front of us. Maybe they're on the projector, right? You have each choice written down, and then you take time to rank them. You can either score them, everybody scores every idea 1 to 5, or what I like to do is everybody gets a certain number of votes. So there's 20 ideas, vote for your top 3. And everybody goes around and votes for their top 3, either in a document, on the wall, however you decide to host your session. Now, that is list reduction, right? We're refining down the ideas, but it's also forcing us to rely on the expertise in the room to prioritize strategies. Now, what's really important is if you do this, you have to leverage the ideas. You can't ask everybody for feedback and then ignore them. And this happens sometimes in organizations where we have this real participatory approach, and then nothing happens after the meeting. People are like, whatever happened? We all voted for these ideas. Did we do the thing? And they're like, oh, no, it was expensive. Or, oh, no, we started working on something else. If you're going to be a leader and ask for people's opinions, you have to respond. You have to engage with it once you've asked for it. It's really important. Now, one of the other tools that we use, in addition to just list reduction, breaking it down, is something called an affinity diagram. Now, the next few slides go over how to create one, but I'm just going to show you one at the end of the presentation and come back to this. This is an affinity diagram, okay? This is a document, and you can tell their goal is to maintain an effective performance improvement program, and they want to know how to do that. So at the top, you would have whatever your problem is: surgical site infections, patient falls, right? Increasing patient experience. And then you would have all your ideas. All the little squares below are all the ideas that people came up with. The ones that you refine down, your top ideas maybe. Now, what is happening in the affinity diagram is it's not a process diagram. Each one of these greater categories is a broader theme. So what they did was they grouped all of their ideas under themes. We have a customer focused theme, a process focused theme, a measurement focused theme, a leadership focus, and a communication focus. So we've got these new communication strategies we're going to do. We've got these new leadership trainings. We got everything is sorted. So basically all an affinity diagram is you take all your ideas, all the suggestions that stood the test of time, right? That everybody agreed, like, yeah, let's keep this on the list. You take those and you group them under themes. Now, the themes could be departments. You could have case management's going to do this and finance is going to do this. The themes could also be something like cost. That you could group it however you want. This specific grouping I kind of like in this diagram because it's grouping it by the type of effort. What are we doing that focuses on the customer? What are we doing that focuses on data and measurement? Kind of interesting. But that's all an affinity diagram is. So we've got this process here, but essentially you conduct the brainstorming, you do your list reduction, you get all the ideas together, and then you sort them into themes so that you can develop an action plan. If you take this, you can make it into a grid where we've got all of our customer focus strategies on one tab and all of our new process strategies on another tab. Now, do those terms make a lot of sense for you right now? Maybe not. Like for me, I'm like, well, what's the difference between something that's process focused? We're not here to debate that. This is just their example. But you could have something that's all the business management strategies, all the data analytics strategies, all the IT strategies, right? And you could group them that. The last slides here are about making sure that everything we're capturing is about determining what is critical to quality, what people actually care about, their quantifiable customer requirements. And it's funny because these slides talk about treating it like an equation. 2 times X plus C equals Y. The idea that what we want to get to, the Y, is a feature of all these inputs. And so we may have 2, 3 things that we need to do really well are critical to qualities that drive that output. And this is a critical quality tree that shows the thing that we're trying to address and all the things that are major inputs to that. I like this a little bit more than the affinity diagram, but this is problem focused. We need to address time on hold. We need to address call pickup time. It's not the strategies. The affinity diagram might have those strategies that we brainstormed to address what we know the problem is. All right, well, I hope this was helpful, a little overview of some of the tools we use when we're trying to define a problem. Our next lecture I recommend you listen in on is our measurement phase, moving from D to M in DMAIC, where we'll talk about how we measure a process so that we can start improving it and really analyze some data. All right, well, thank you so much. Have a wonderful week.